So the ISTDP stands for Intensive Short-Term Dynamic Psychotherapy, and it was developed during the 60s to the 90s by Habib Davanlu. And it's a fairly new method in Hungary as well. So one of the goal of our initiative, ISTDP Hungary, is to make this psychotherapeutic method to more accessible and more available for healthcare professionals. So that is why we are organizing online lectures and meeting events, trainings, and workshops. So today's workshop is about medically unexplained symptoms to help some somatic patients. And that is why we are really, really happy that we have so many medical doctors among our participants today. And it's a really great pleasure for me to introduce our presenter today, who may be needless to say, but has a Hungarian heritage. He is a licensed clinical psychologist in Washington, D.C. and Pennsylvania, working with both short and long-term psychodynamic psychotherapy. He's a co-founder of the Institute for Emotions and Health, which is focusing on the diagnosis and treatment of medically unexplained physical symptoms. He also served as a faculty chair of the ISTDP training program at the Washington School of Psychiatry, where he was also a faculty member for 5 years. He also offered courses and supervision to clinical psychology doctoral students at George Washington University and the Chicago School of Professional Psychology. So welcome, Dr. Maury Joseph.
Hey, thank you so much. It's really a great pleasure to be here. Thank you for inviting me, and we should start so that we have a lot of material to get through today, and I hope you'll find it useful and interesting. We were working out some technical difficulties, but I think I solved it just in the last moment here. So let's test that. Can you see the PowerPoint now?
Yes.
Yes. Okay, good. All right. So at least we have that. Okay, and there's something going on with my camera, so it's going to give you an artistic representation of me at times, and I'll just fix it when that happens. I don't know what's going on there. So this is, I'm calling this presentation Psychological Aspects of Somatic Presentations, 6 Key Pathways, and there's my information there, Maury Joseph, and you can find me at my website, mauryjoseph.com. And for more information about the aspect of my practice where I focus on the medically unexplained symptoms, psychophysiologic disorders, you can visit IEHDC.com. All right, now let's see if this slideshow will advance. Okay, so yeah, about me, I'm a certified trainer and supervisor of ISTDP. I'm just very interested in the treatment of medically unexplained physical symptoms, and I have found that ISTDP is an extremely useful type of therapy or approach to therapy to learn if that's a area of a patient population you want to work with. I'm also especially excited to be here because as Kata mentioned, I do have Magyar roots. Both my grandparents on my father's side grew up in towns. The towns are now part of Slovakia. They were absorbed into Slovakia when borders changed. But Hungarian was their mother tongue. They always identified as Hungarians. And in 2016, my family and I came back and we went to visit the towns that my grandparents were from, and we spent time in Budapest. We went to the place where my grandpa trained as a plumber in a basement off of Jokai Square. You probably know where Jokai Square is. It's a bar now, but it used to be a plumbing shop. And my brother and I drank Slivovitz in a bar that was a place where my grandpa trained to be a plumber. So very special to be connecting with the Magyar ISTDP group for me. So our goals for today are to learn 6 different psychological processes that can lead to medical referrals and to medically unexplained physical symptoms. And we're going to look at this so that maybe you'll have a better idea of when to consider a referral for psychotherapy or for a psychiatric workup. And also, we're going to learn this so that we can reduce inappropriate referrals that end up on a medical caseload, right? Because it's my impression that having these sort of psychophysiologic, psychogenic disorders in your somatic medical practice can be frustrating both to the physician and to the patient, and can lead to some amount of burnout for both patient and therapist. And beyond sort of just this conceptual piece about these different pathways to symptom creation, these pathways of psychogenic symptom formation, we're also going to talk about treatment strategies, especially from the perspective of intensive short-term dynamic psychotherapy. So you can learn more about what your ISTDP colleagues are up to. All right, so just to say a bit about the nature of the problem, here's just some statistics that you could easily find. There's references at the end of my presentation. 16% of people in one study leave the emergency department without a medical explanation. And that includes 75.8% of people who present with chest pain, right? 75.8% of people who present with chest pain, they have their EKG, they have their echocardiogram, they have whatever imaging and blood testing, and it yields no new diagnosis. They just get an atypical chest pain diagnosis, and so there's no real explanation for why the symptoms are happening. 84% of referrals to internal medicine from the emergency department yield no new diagnosis, no new explanation of what was causing the presentation. 25% of specialist referrals yield no new diagnosis. And so that causes major questions about the cost effectiveness burden that happens when people are suffering from medically unexplained physical symptoms, and also the costs of physician burnout and patient burnout. Patients come looking for an explanation, looking for a cause, looking for a treatment that targets the cause, and if we're only thinking about their symptoms from a purely somatic approach without considering any psychological factors, it can lead to burnout for the physician and sort of false hope and burnout for the patient. I also think presentations like this are important because, I'm not a physician, but my understanding is that the medical curriculum does not emphasize the ways that psychological factors can impact physiological somatic presentations. And so I think this can be important education for physicians that's left out of sort of the mainstream medical curriculum. I hope you'll agree with me that that is the problem. So to help you today, I'm going to encourage you to think about the body as an organ of the mind, right? And this is an idea that goes back to Freud and probably precedes him, but Freud saw the body as discharging the mind's tensions, and the body also as a location of meaning, as an organ that communicates meaning for the body. Walter Cannon, the American physiologist, who gets a lot of credit for developing our understanding of the physiology of fight or flight, the different physiological responses that occur when the organism perceives threat or feels under threat. And we're going to look at the work of Habib Davanloo, who took these ideas from Freud and Cannon and made them clinically useful, therapeutically useful. And we're going to show you how we can apply them clinically. But that's our main focus today, is thinking about the body as an organ of the mind, as an emissary of the mind, as a location where psychological factors express themselves. And one really useful sort of dichotomy, even if it's ultimately a false dichotomy, it's still a very functional dichotomy for a lot of cases, comes from the American psychoanalyst Merton Gill in his 1994 book, I think Psychoanalysis in Transition. He comes up with two categories of psychological processes that cause somatic presentations. And he calls the first one the body as such. So this is the body doing what the body does. The body's trying to maintain homeostasis. The body is tensing the muscles to ready for fight or flight, and then it's discharging that tension, releasing that tension. It's preparing the body for danger. It's adjusting the interior of the body for dangerous situations or for relaxing and safe situations. So the body as such is sort of just the body doing what the body's supposed to do when it's under threat or when it's under stress. And that'll be part one of this presentation. And then part two is the body as a location of meaning. So this is where bodily symptoms serve a communicative purpose or an expressive purpose, a purpose of communicating something within a relationship. These are situations where the body is expressing something that the mouth cannot. For psychological reasons, the person can't say what they're feeling, and so their body learns to say it for them. And we'll look at different examples of how that can happen. So we're going to start with the body as such. And the main thing we're going to focus on today is anxiety. So anxiety, why does it happen? Anxiety occurs in the body when normal coping, when our normal strategies for navigating the world and keeping ourselves feeling safe seem to fail. And as a result of the failure of our normal coping, our normal sort of defensive structures that keep us feeling safe, we have the experience that something dangerous, something frightening, something threatening is nearing awareness. Now, this could be emotions that are taboo. This could be feelings that are taboo, impulses that are taboo, interpersonal challenges that are new and threatening to us, new relationships, new styles of relationships, new roles, either professional roles or family roles, and also separations and losses. So the subject, the person, the emotional system of the mind experiences something threatening nearing awareness. And according to Freud, as a result of that, anxiety would be experienced in what Freud called the ego. Habib Davanloo, who founded ISTDP, took this very Freudian idea that a threatening stimulus would trigger anxiety in the ego, and he made it clinically usable by showing that anxiety being experienced in this sort of hypothetical abstract ego would be visible and observable in the body of patients. And we're going to look at some examples of that. And Davanloo also offered the perspective, and this is part of what makes ISTDP very useful for treating these, or at least investigating these medically unexplained physical symptoms, that because anxiety patterns would be, well, he offered the idea that anxiety, these pathways of anxiety, these patterns of anxiety in the body can cause or exacerbate, worsen medically unexplained physical symptoms. And we're going to talk about how that works. And he identified 3 patterns of activation, that is sort of broad categories of activation that would be part of anxiety, possible anxiety response for the human organism. So first, pathway 1 is the striated muscles, pathway 2 is the smooth muscles, and pathway 3 is what he called cognitive and perceptual disruption. And we'll look at examples of all of that. Pathway 1 is the striated muscles. So I know there's a lot of physician colleagues here. You already know what this is, right? These are the large voluntary muscles of the somatic nervous system. They're called striated because they have these long striated, structures to them. There is a, here we go. Davanloo found that the striated muscles get tense in a particular pattern. Here, I'll fix my camera. Sorry about that. Let's see. That the striated muscles get tense in a particular pattern that he could identify by watching videotapes of his own clinical work as a psychiatrist. And he found that the tensing pattern starts in the fingertips with a kind of pill rolling type pattern. Then you'd see it move to hand clenching. You might see a patient grip the hands, the rails of the chair, and you see tension in the muscles around the hands, moving up the forearms, up the back of the neck, the sternocleidomastoid muscles, the forehead, the jaw, and down through the trunk. Especially, you would see tension in the intercostal muscles between the ribs, which creates these large sighing respirations. So the sighing respiration is sort of a clear, visible clinical indicator of a person who is experiencing striated muscle tension from anxiety, as would be hand wringing, and as would be other types of discharge, like sometimes giggling. Someone's nervously giggling to discharge striated muscle tension, and also sort of gross motor movements when someone's moving around a lot in the chair, shifting from side to side, things like that. And he found that this tensing pattern, this is just sort of like an interesting, just bit of physiology, but he found that the tensing pattern followed the motor cortex, the motor homunculus up the side of the motor cortex, up the side of the brain. And if you can see on the left side, you have the fingers moving up the arms, shoulders, head, neck, trunk, hip, legs, moving up that motor homunculus on the somatosensory strip. And it's just very interesting that the anxiety activation pattern seems to follow that. There's a large number of physical conditions that can be associated with, caused by, or exacerbated by striated muscle tension. A very common one is fibromyalgia, TMJ, temporomandibular joint disorders because of tensing in the jaw, the striated muscles of the jaw. Oh, that's happening a lot with my camera, huh? Sciatica, from tensing around the lower back and upper legs. Tension headache is very common in this group of patients. Hyperventilation or difficulty breathing, right, because of the tension in the muscles around the ribs and the diaphragm. Muscular pain, tingling hands and feet, right? You can wind up with neurology referrals because the patient has tingling hands and feet, but that's because all their blood flow has gone to their large muscles for this striated response. Choking sensation, what used to be called globus hystericus, and also cramps and tremors just from chronic striated muscle tension. All right, so let's stop recording for a moment and I'll show a video.
Fidgeting, but it would be like a false alarm, false sign.
Yes, absolutely. Is there like anything specific you're imagining or a situation you could think of where that concern would be present for you, or?
Well, of course, I have some ideas too, like I would imagine if the temperature isn't right, it's too hot, too cold.
Sure.
Things like that. But I would just wondering if there is something specific that we need to pay attention to.
I think that's a very good question, and maybe okay. Can you see the PowerPoint now?
Yes.
Oh, good. Thank goodness. Yes. So that's an excellent question. It is maybe a little advanced for our goals today, but I will answer it anyway. I think we always, at any time, we want to be looking at the context in which the symptoms are occurring, right? So, if let's say the patient is talking about something stressful, they're facing something they've been avoiding, they're facing something that makes them anxious, then that is and then we're seeing these striated muscle signs. Or let's say you have a patient who is going through a stressful time and all of a sudden they're developing tension headaches, and the tension headaches are not responsive to medical interventions. Or it's a patient who has been having difficulty breathing, shallow breathing, and imaging, testing, and first-line medical interventions are not producing anything. Then you start looking at all the way these data points are lining up, right? The way these data points are converging. And you could say, okay, it could be, all right, we have a patient who's under stress, experiencing a physical symptom that doesn't yet have a medical explanation. And we see that when he's talking about the stressful situation, his body goes tense. right? Then you have sort of multiple lines of converging data that suggest striated muscle tension is part of the picture, part of the diagnostic picture. But you also wouldn't want to ever make assumptions, right? You would want to make sure that the medical testing and first-line medical interventions have at least been tried. And I'm sure that there are other there are other things that could cause a person to be sighing and tense other than anxiety. I guess the goal for today is just to sensitize the audience to the possibility that and to the sensitize the group to that pattern, so that people will be more likely at least to consider that the striated muscle tension could be contributing to these kinds of symptoms. Does that make sense? How does that work for an answer? Can you hear, did you hear all that? You could all hear all that?
Yes.
Yep.
Okay, good. So yeah, but it's a good question. You know, we should never assume that a physical symptom is psychosomatic, right? That would be very dangerous. It's equally dangerous to assume it's always dangerous to make assumptions, right? To assume a physical symptom is psychosomatic, to assume a physical symptom is purely somatic without considering psychological factors. There's many jokes about psychoanalysts who die of very treatable conditions, but they never went and got treatment because they figured they were somatizing. Okay, pathway 2, the smooth muscles. The smooth muscles, of course, are the mushy muscles that line the. And for that reason, these folks are very often referred to medical settings because they don't appear classically anxious, right? Our sort of common conception of what an anxious person looks like is that they're tense. You know, they're shifting and they're tense and they're tight and they're sighing. And so very often patients who are in smooth muscle activation will be referred to medical because we're not thinking, oh, this is an anxious person. There's a link in terms of their personality. There's a link with depression, high correlation between depression and smooth muscle types of anxiety, anger against themselves, self-critical tendencies. And there's a lot of very difficult to treat from a medical perspective, diseases that may be associated with or made worse by smooth muscle activation. Hypertension, irritable bowel syndrome is probably the most classic one, functional dyspepsia, any of these acid, spasms, diarrhea, nausea, constipation are very common among people, suffering with smooth muscle anxiety. Migraine, there's also, of course, a correlation between migraine, IBS, and depression, right? I didn't look up those statistics, but there's a pronounced correlation between all those. Sexual dysfunction, right? The smooth muscles of the urogenital system. Ulcerative colitis, reactive airways, right? Like a hyperventilation disorder, might look like asthma, but not responsive to asthma treatments. Bladder spasms, abdominal pain, sudden urges to urinate and defecate, all of these can be associated with people who are experiencing smooth muscle activation. I'll show you the graphic here. Oh, and with therapy, we see patients who are anxious in their smooth muscles shift to striated muscle tension. And I'll show you that in this next clip after I fix whatever's going on with my video. Okay, and here's this beautiful graphic, which Kata, did you create this?
We created with a small team, 3 of us. One of them was a graphic designer, and the other one is someone from our core training here.
Yeah, it's really good. Where can our colleagues access this? Is this it's available on your website or?
We can send it out.
Yeah, so this is the best, many people have made graphics of the pathways of anxiety, the patterns of anxiety. This is the best one yet and the most comprehensive and visually appealing, created by your colleagues in the ISTDP Society. And you can see in the orange, the yellow, the different smooth muscle systems and the different symptoms that can be made worse by tension or changes or dysfunction in the smooth muscles. So let's stop the recording again, part of the PowerPoint, and we can resume recording, right? Okay, pathway 3 for Davenlu was what he called cognitive and perceptual disruption. Again, this is a group that will have limited access to striated muscle tone. You know what, I'm just gonna stop the share for 1 second, fix something. Yeah, limited access to striated muscle tone. They're gonna look limp. They're not gonna look to have much motor power in the sessions. Davenlu hypothesized that this was an effect on the brain of a reduction in blood pressure and blood flow as a result of a sort of severe fight or flight response. There's a correlation, a link you can make with more severe and more early trauma. And as a result, people have much more severe intolerance of anxiety. And so anxiety will impact their bodies much more severely. And this is anxiety that interferes with cognitive and perceptual functions. So you'll see drifting, right? You ask the patient a question and they're like, huh? Almost like, they didn't hear you. Losing track of thoughts, poor memory, right? They forget what you talked about in your last meeting. Fainting, mind going blank, dysfunction in the sense organs. So things like tunnel vision or blurry vision, ringing in the ears can be part of this pathway. And they'll have pseudo-neurological complaints like dizziness and fainting. And they'll also have like random injuries sometimes as a result of cognitive inattentiveness, bumping into things. They'll be accident prone. And with therapy, you'll see that as their anxiety tolerance improves, they'll shift to smooth muscle. So all of a sudden, somebody who their mind used to go blank, or they had troubles with attention and cognition when they started the therapy, they will go through a phase of therapy sometimes where instead of that, they'll have stomach aches. And that's sort of on their way to having more striated muscle tension. So you'll see that patients sometimes, as they improve, will go through these different pathways. And then let's stop the recording. I'll share how that looks in terms of body systems. But I can answer speculatively that something like prefrontal cortex has more capacity to observe and think about and adjust to amygdala lower brain anxiety. And so the subject, the person is, so let's put it this way. It's not like the anxiety goes away, right? Life is still scary. Life is still full of threatening stimuli. But the anxiety feels less threatening, less dangerous to the person. And so they are not having such a severe anxiety response. So like, the cognitive perceptual disruption, many people link that with like a freeze response, where basically the organism is under mortal threat and needs to basically play dead, right? Endogenous opioids flood the brain, cognition and perception are interfered with. And people speculate that that's what happens in like a deer when it's being eaten by a lion, right? So for this patient, right, she's just coming to see me in my office. I'm like this friendly guy in downtown Washington, D.C., but her body and mind respond as though I'm a lion about to eat her, right? So the idea would be that as the therapy progresses as her ability to, what's a good way to think about it? Distinguish real from perceived threat improves, as interpersonal relating and sharing her thoughts becomes less and less of a mortal threat to her nervous system, then you would see things start to shift. So that's my attempt at an explanation. We would probably need a panel of neuroscience people, affective neuroscience people, psychoanalysts, to offer you a better answer than that. But that's my best try. How does that work for you? I mean, what any thought? Yeah.
It's acceptable. Thank you very much. I can progress it. Thank you. That's perfect for me.
Okay, it's a start.
I also had the second question. Could I ask it perhaps? Like the woman in the video, like how could you decide that she was eligible for ISTDP? Because I thought that the ability to express herself is important here when making the decision during the first interview. And she doesn't really look like the type who can express herself easily.
Yeah, that's a good question. Well, I can think of maybe a couple ways to answer it. One way is that she is expressing herself, right? And expressing herself very clearly and kind of beautifully, right? Even though she can't use words in that very moment, she is showing us, right? It's the difference between show and tell. Some patients can come into the office and say, well, Dr. Maury, I'm very tense today. I'm very anxious, right? And some patients come in and they say, right? And so in some ways that's highly communicative and does give us a basis to begin working, because you can see I sort of can move in, I can begin asking questions, encouraging, for lack of a better term, encouraging prefrontal cortical activation, encouraging self-reflective centers of the brain to turn on and think, that could observe the anxiety and thereby reduce the anxiety, sort of through a kind of mindfulness. And so that's one part of the answer. Another part of the answer is I think ultimately the best judge of whether someone is appropriate for a particular kind of therapy is how they respond to the therapy. That's where the idea of like a trial therapy comes from, right? So I wouldn't assume at the outset that, just because of how the person presents in the beginning of the session, I would rule them out for a particular approach to therapy. I want to see how they respond to my interventions before I make that determination. And I want to see how it is subjectively for them. Like, does this feel helpful to her? Does this feel like something she wants to continue to pursue? And also, ISTDP, right, is more than one therapy. ISTDP is a whole family of different therapies of different intensities that can be graded and tailored to the specific needs and specific deficits of the person. So with her, I wound up using an extremely graded approach, extremely gradual, and with a lot more emphasis on reflecting together, thinking together, and regulation of anxiety. Whereas with another patient, I could still say that I'm doing ISTDP, but the therapy would look radically different with much more focus on affect and experiencing affect. And that's one of the innovations of Davenlu, was to create a sort of frame of therapy that could be tailored to all these different types of presentations. So I think I covered all the thoughts I had in response to your question. I hope that's helpful.
Absolutely, thank you.
Okay, good, excellent. Any other questions?
I have a question. Is there a difference in the quality of anxiety whether somebody has got a tension headache and just making gross movements on the couch? Mm-hmm. I don't know. Do you think there is any difference in the quality? Because both of them are striated muscle. both of them express striated muscle anxiety, but still, I mean, in my perception, there might be some difference between getting a headache than just moving, because it's really active. I mean, just moving on the couch.
That's a good question. I mean, I think that those large gross motor movements where the person is making these big shifts and crossing and uncrossing their legs, moving the pillows around, fixing the jacket, those might be signs of sort of a higher activation where really the whole body is anxious. And so all the muscles in the body are having to work at discharging anxiety. And then tension headache, right? Tension headache is about halfway through that pattern that Davenlu observed, where it starts in the fingertips, moves up the arms, shoulders, and then to the muscles of the neck and face, right? So maybe the person is not tense all through their body when they're having a tension headache, but sometimes you see people who are like polysymptomatic, right? Where they have a tension headache and they have numbness and tingling in their feet, and they feel difficulty breathing. So I don't, does this answer your question? Am I getting at what you're asking?
Sure. I mean, kind of.
Yeah.
And
yeah,
do you think the person can have both a striated muscle and a smooth muscle anxiety at the same time? So
yes. I think you'll see sometimes with people proportions of each, right? So even the guy I showed who was nauseous, right? It's not like he was completely flat. It's not like he was melting in the couch. He had, and same thing with the woman who was stuttering. But what you tend not to see is someone who's nauseous and having a really profound striated muscle signal. So somebody who's nauseous won't be taking big, deep sighs and won't have really good clenching pattern. And sometimes you'll see it almost looks like the body is trying to mount a striated muscle response, like the body is trying to move itself as the work is happening from a more, like, for instance, nauseous response to a more tense response. Like let's say patient comes in nauseous, you're focusing on what's happening in the moment, you're trying to think about it together, trying to examine it together, trying to have a new experience together, and all of a sudden you see kind of weakly, but it starts to happen, that the fingers start moving together, right? And then you see a little bit of tensing in the fingers and tensing in the hands. And there may still be some nausea while that's happening, but it's like you're starting to see the striated muscle channel ascend. So, like I said, unfortunately, these can't be perfectly discrete categories, but they do have this heuristic value for sort of making generalizations, forming hypotheses, so you can, decide how to intervene. Okay, thank you. All right, well, let's move on, and I'm sure there will be more questions. You can write them in the chat, but I want to make sure we get to all the information and some more case examples. This part is very interesting to me. It's the body as a communicator of meaning, the body as a location of meaning. And when you think about it, these are going to be just sort of extreme examples of normal human interchanges that you see and experience and are a part of every day, right? Like here in America, I don't know how it is there, but here in America, sometimes in the middle of a conversation, someone will look at you like this, right? And so that's a nonverbal communication, right? And it means, okay, Maury, your turn to talk, right? And if we're socialized properly, if we had normal psychological development, we get that message, and then we follow the message and we begin to talk, right? So that's the body being used for communicative purposes, the body being used to express meaning rather than words. And then there's basically more severe and significant and profound and more life-altering variants of this, right? Where these become, what's the best way to say it? Life-altering or highly uncomfortable pathological physical symptoms, right? Where the body is trying to express something that the mouth cannot say, but in sort of a profound and life-changing way. And all of these can contribute to inappropriate physician referrals, right? Where the patient is being sent from specialist to specialist, trying to find a medical cause, right? And no cause is showing itself. You know, and these can wind up being sort of medically unexplained. And one thing to say, it's funny, you know, that this idea of being medically unexplained, it's a misrepresentation, it's a misnomer, because ultimately there has to be an explanation, right? It's really, I think the reason I use this term is because by the time the patient gets to me, by the time the patient gets to my office for a consultation, the symptom does not yet have a medical explanation. You know, so we're hoping to find the possibility that there is at least some psychological contributor. So the first way of looking at the body as a location of meaning is to go back to this Freudian concept of conversion. Freud coined this term in the early 20th century, maybe even the late 1890s. Also, there's a link here with a Hungarian forefather of psychoanalysis of the Budapest school. I don't know how much you study him there now, but Sándor Ferenczi was a collaborator with Freud. He also wrote about conversion. He was very sensitive to these transformations from the mind to the body. So Freud saw it as an energy transformation from the psychical to the somatic. So that was his metaphor, the metaphor of energy, bodily energies, where essentially some thoughts or feelings or conflicts from the mind would be expressed via the body. So the classic one was what was called then a glove hysteria, right? Where for some reason one of the hands, and it was often in a woman patient, where the hand was numb, limp, it had lost its motor power, even though all nerve pathways going up to the shoulder were normal. And Freud was finding, and his colleagues were finding, that this was a hysterical manifestation. It was psychosomatic, and it was expressing feelings and thoughts and wishes that the patient themselves could not express. So for women in sort of late Victorian era Vienna, there was a great deal of psychological conflict about their wishes to touch themselves and to be touched, right? So the glove hysteria was a sort of a compromise between the wish to touch themselves with this hand, or the wish to touch somebody with this hand, with also the cultural admonition that you mustn't, right? But it also had this unique factor, which Freud called the secondary gain of the symptom, which is that, sure, because you have this symptom, you can't touch yourself as you had wished to, but now you can go see a male physician and you will be touched by the male physician, right? So even though your sort of wishes to touch yourself, for instance, would not be gratified by this limpness and loss of power in your hand, you could still get gratification because now you're getting the attention of your family, you're getting the attention of your doctors. And so that's an example of secondary gain, which is really these gratifications that are created by the symptoms. This is very important, especially as physicians and as psychologists too, when we're trying to make a differential diagnosis, when we're considering the possibility that emotional factors are playing a role in the symptoms. We want to be looking out for ways in which there are gratifying or relieving aspects for the patient to having the symptom that may reinforce the symptom, make the symptom attractive, make it useful, make it necessary. So we'll get to some examples of this, but so just a couple types of secondary gain. One would be avoiding maturational challenges, right? You have a student who goes away to university for the first time, and all of a sudden they have crippling migraines, crippling headaches, can't work, can't go to school, and of course they have to return home, right? So they avoid the developmental challenge of separation, of individuation, the challenge of work by becoming ill. And another pathway is to punish others. Like, you may know this from your own practice. You may know this from your medical practice. There are some patients who it seems like they stay ill almost to spite you. It's like they don't get better, almost to drive you crazy, almost to make you feel like a failure. Or people will stay ill to punish a loved one. Like, see what you've done to me. See what our relationship is doing to me. It's giving me these stomach aches. Every time we fight, I get sick to my stomach. So patients can hang on to their symptoms because it has some additional value to them. That's something to be attuned to. So Freud thought about conversion as a loss of function in some somatic structure, usually to express conflict. And of course, he was very interested in sort of like sexual meanings of symptoms. Davenlou is very interested in sort of aggressive and destructive meanings of symptoms. So Davenlou would talk about and describe a loss of motor power to prevent physical violence, right? So Davenlou is investigating angry impulses, rageful impulses that patients would feel if they were getting in touch with angry feelings. Like, I'm so angry inside, I feel like I could smash somebody's head, right? And then the patient would suddenly get limpness or weakness in their hands and arms, right? I had a patient who was in constant conflict with her roommate, and the patient, when they would have a fight, my patient's legs would get heavy and numb and feel like sandbags. And what we came to find was she had sort of unconscious wishes to stomp during these fights, right? And her through motor conversion, her body would make that impossible. So the conversion for Davenlou is both a way to prevent the violence by making the motor movement impossible, but also to punish the patient unconsciously for their violent impulses. And so there's a link with depression, with these conversion type symptoms. And if you think about your average depressed patient, you see a lot of psychomotor symptoms, right? They feel weak, they have anergia, they might move slowly in your office. And Davenlou's theory about this, at least, would be that this is sort of some restrictive or repressing part of their mind, and some guilting, punishing part of their mind, trying to prevent their body from fully feeling its anger and whatever impulses would be attached with that anger. But this is another Freudian term, somatic compliance, right? Very often with patients with conversion or somatization, they will have had some injury in the past that makes it possible for their mind to now use this symptom in the present. So my patient had a bodily memory of hand pain. And so when her mind needed something, needed some symptom to send her back home, to get her away from the challenge of the university, her mind could sort of pull up this memory of pain to use as a symptom. Patients have memories of pain, memories of dysfunction that can be used in the service of creating these symptoms. Just to upset you all a little bit, if you've ever had a paper cut of communication and prohibitions against, or punishments against honest communication, that the body will learn to be the communicative organ. So you see this many times, like I treated a 12-year-old girl who was being bullied at school, but she was really afraid to talk about the bullying with her parents, right? Instead, she developed stomach aches, nightmares, and having poor sleep so that she could just miss school, so that she could stay home from school, right? So again, it's a mysterious thing, right? How does this happen? How do these emotional things leap from the mind to the body, right? but this is one theory I have about why it happens. It's the body learns to communicate what the mouth can't say. And maybe another day in another lecture, we could get more into why I think that. Okay, somatization, what have been called sympathy symptoms. This is when a patient is unconsciously identified with an injured person. So this happens very often with somebody who has been caretaking a loved one who is dying, or a loved one suddenly dies. And because of grief, because of their love of the person who dies, and also a refusal, an emotional refusal to accept the separation, to accept the loss, the patient will sometimes take on the symptoms of the deceased. So, you know, I haven't, this is something I've only read about. I haven't seen anyone personally with this, but you'll hear about, like, you know, somebody loses a loved one to lung cancer, reactions all the time, and we don't know what it means. But many people are intolerant of that absence of meaning. They're intolerant of that unknown. And so they seek the wisest people they can find, their physicians, for answers. And they want those answers fast. They want those answers to be reassuring, right? So you'll have patients come, you know, and very often they're convinced they're dying. They're certain that, you know, they've developed some lump, and maybe it's nothing, or they've developed some physical symptom, and maybe it's really nothing. It's something that'll go away on its own, but they're convinced it's the first sign of cancer, or the first sign of Parkinson's or Huntington's, or, you know, something catastrophic. So some patients come and they just want reassurance. They get the reassurance, they go away until they get anxious again, and then they come back for more reassurance. Some patients, and these are what are called hysteroparanoid syndromes, these are patients who invite intervention, but they're hostile to it. So they sort of beg you for care. They come to the hospital or to your clinic seeming desperate, seeming deeply in need, but they also argue with you about your efforts to intervene. They complain about side effects. These are people with whom the nocebo effect is very common, as opposed to the placebo effect, where you're giving them drugs and the side effects are very confusing. The side effects don't make sense. They're not normal side effects. And there are patients who tend to, you know, they invite you to intervene, but then they have a paranoid, suspicious, doubting attitude towards your interventions. And I know that's very annoying for physicians. And those people can be very, very useful referrals to psychology, psychiatry, because very often the issue is there may be some underlying medical issue that does need to be treated, but their interpersonal style, their interpersonal way of relating to physicians, and their interpersonal way of relating to treatments, because they have these suspicious, paranoid feelings even towards a pill, will lead them to have a bad response to a treatment that would work for other people. So these are patients, if you see that pattern of sort of the desperate need for help, the desperate need for assurance, but also the paranoid, suspicious, hostile response to your interventions, those can be really good referrals for psych. Okay. Let's skip this stuff a little bit. Just so we have plenty of time to watch the video. I do think, actually, let's just go through it quickly. I think in your role as physicians or as psychologists, you really can play a role in beginning the process of differential diagnosis, right? Just through observing what's happening when you're interviewing the patient, right? You have maybe 15 minutes to speak with the patient while you're making a diagnosis. Are they holding tension? Are they sighing? Do their symptoms conform to one of the patterns of anxiety activation that we discussed? Are you hearing bowel sounds in the meeting? Are they running off to the bathroom when they're talking about, you know, they start talking about current stressors in their life, and all of a sudden urge to defecate and they have to run out of the room? Do the symptoms get worse while they're talking about it? Are they getting cognitive and perceptual problems while they're talking to you? And also a very important thing is there a co-occurrence with a stressful event and the onset of the symptoms? Like, somebody just became a parent, they just had a kid for the first time. And then all of a sudden they're having chronic tension and stiff neck, right? And testing is not revealing any medical cause for the stiff neck and the tension in the shoulders. Maybe that could be a time for a referral to psych. So you want to investigate, do the symptoms change with stress? Do the symptoms get worse when there's interpersonal conflicts? You could even ask them for a specific example of a time when the symptoms had a sudden onset or became worse. And if you find that the symptoms do get worse in interpersonal conflict or in times of stress, then you can make an informed referral for psychotherapy. You could say, this could be then at least partially caused by stress. So maybe you want to go talk to somebody. So those are ways, just as a physician, just in your own consulting room, you can begin to work at this problem and formulate whether a referral to psychology would be appropriate. And then just to support the ISTDP movement in Hungary, the training group there, there is a great deal of evidence. This is not even all the studies. There's a sort of a large number of studies now that has found medium to large effect sizes for somatic symptom disorders using ISTDP, intensive short-term dynamic psychotherapy, the Davenlu work, including for children and adolescents. There's more data emerging for IBS, functional dyspepsia, pseudo seizures, definitely effective ISTDP, headache, of course, especially these tension headache and migraine, psychogenic movement disorders, some very fascinating work being done on psychogenic movement disorders, pelvic pain and urethral pain. And there's also a great deal of cost effectiveness data, right? There's like a 40% reduction in use of emergency departments year to year in people who have a short course of ISTDP. That's just one memorable statistic, but there's lots of other data. Like $1,000 in cost savings in cost savings for patients in a year following a short treatment course of ISTDP. So it's definitely good for reducing the burden on healthcare providers and on patients. So hopefully there's a directory now of ISTDP trained therapists in Hungary, and you can, if you're finding these psychosomatic patients, psychophysiologic patients, somatic conversion disorder, anxious patients, you can find a therapist to refer them to. Because I do think the ISTDP training makes clinicians uniquely prepared to address all these kinds of things, because you're studying these different pathways of symptom development and you're learning ways to intervene effectively with those. So we have a little time left to look at some clinical material, just so you can see a little bit of treatment process, just with one case, right? This is going to be just one example of how I work with one person. It's an old case. It's from 5 years ago. I might not even work with him in exactly the same way now, but it does at least give you some idea of how we think about these problems in the psychotherapy setting and how we might begin to try to address them even in the first session. So before we do that though, what questions are coming up for the group? Please ask any questions. I have stunned you into silence.
I think we are eager for case materials.
Okay, we can do that.
Could it, please?
What's that?
Yeah, I had some questions and some comments, but maybe it's better after the presentation, or we can do both.
Well, yeah. Why don't you ask now? There's still plenty of time for video.
Yeah. Okay. So I work a lot with psychogenic seizure patients.
Oh.
And so I have some comments about that. That, for example, the naming medically unexplained terminology, we have also a problem with our terminology because it is psychogenic non-epileptic seizures.
Right.
Which means that you are calling something which is not. You are saying a negative. You are not saying what it is. You are saying what it is not, which is absolutely not a practical and not a philosophically is not a good way to name something. And there is a small comment to this that I have seen in your PPT that you call it pseudo seizures, which we generally try to eliminate because it has a negative connotation that the patient is mimicking the seizures, or I don't know how you call it. So it has a negative connotation. So we generally try to ask to eliminate the pseudo seizure naming because it gives a kind of a stigma to the patient. And that is connecting to my other question, that how do you see the medical community attitude? Is it changing to psychogenic or psychosomatic or somatization, or is it still a very difficult psychological and psychosocial situation to be a medically to be a psychosomatic or psychologically explained disease?
Yeah, I can only say, first of all, thank you for addressing the comment about proper terminology for the medically unexplained seizures. So you think PNES is the best one? Yeah. Okay.
So
what's that?
It's better still. Right. It has a problem that it is saying that it's non-epileptic, but doesn't say. I like to use dissociative seizures best because it says what it is. Because if you say it's a non-epileptic, then still you don't say what it is. So I generally use psychogenic seizures or dissociative seizures.
That's good.
But the literature use PNES, yes.
Yeah. Okay, and then to answer your question, my experience with the medical community here is sort of only anecdotal, right? Talking to individual physicians who refer to me, and occasionally having done presentations for groups of physicians here. I would say generally, there is a great deal of frustration and annoyance with patients who are presenting with medically unexplained symptoms, especially patients presenting with hypochondriacal types of presentations, reassurance seeking types of ways of interacting with the doctor. And so they're always very happy to have someone to refer those patients to, because they feel like that is a sort of psychological burden on their practice. Because this is somebody who they want to treat, they want to be able to help, they feel they should be able to help them, but they can't. And so, that's threatening to the self-esteem of the therapist, of the physician, threatening to the professional identity. And so what I do know is that as far as I know, it's still very limited in the medical curriculum how much is being taught about the things we're talking about today. But my understanding is that in Canada, where this is much more heavily researched and published about, that's changing. There's been more advocacy to have emotional factors in physical responses become more a mainstream part of the medical curriculum. There's been more funding to have psychology assessments in the emergency department. And there's been more funding for psychology educators to be to be sort of allied with different medical departments. In sort of a consultation role. So I think Canada, and it's also probably more likely that this would happen in Canada because they have a public healthcare system where they really need to focus on cost effectiveness, cost savings. They can't be spending unnecessary dollars on treatments or assessments or testing that turns out to be unnecessary. And a session with a therapist for 45 minutes is very inexpensive compared to an MRI. So if there's even a possibility that there's a psychogenic component to this, yeah, send them to talk with, with Dr. So-and-so. Whereas in America, the healthcare system is for profit. And so doctors are rewarded for ordering more tests, ordering tests that may turn out to be unnecessary, but just doing it maybe just to protect themselves from liability, protect themselves from legal risk. So yeah, it would be good to talk to Canadian colleagues about the changes they've seen.
And the short last question, do you have any suggestions about the communication of the diagnosis that it is a psychogenic disease? Because we have a protocol how to communicate the diagnosis, how to change from a somatic perspective to a psychogenic perspective, which is very important because it can help the psychotherapeutic process if the communication, if the transition from somatic to psychic is very well done, and we give a lot of time to this transition from this attitude, from this point that I am a somatic patient, I am a psychological patient. So do you have any suggestions or any idea about this transition part of the process?
It's interesting because usually by the time people get to my office, they've already seen 14 specialists, and so already by the time they get to me, they are at least entertaining the possibility that there is a psychological aspect to this. And some people come to my office already convinced. They're already certain, I've had every test, I think it's stress. And then there are some patients who are referred to me by their physicians. The physician thinks it's a psychogenic, but the patient still doesn't, right? So they'll come to me and sometimes we'll have a consultation and they don't engage in any therapy. They say, look, I want to continue to pursue somatic solutions. And sometimes people will come to me, engage in therapy, but it'll be therapy about the stress that's caused by their psychogenic or medically unexplained symptom, but they don't have any belief initially that the therapy will improve because they still believe that it's a purely somatic thing that they just haven't yet found the right treatment for. And in those cases, sometimes over time, they do start to realize like, oh my God, as I'm opening up about whatever thing, my percent of my days where I have a migraine is going way down. That's amazing. And so they become convinced, not by my telling them, but by the process of treatment, they become convinced, okay, now I see it had a psychogenic component. But yeah, I think for many people, they have to see proof. Many people won't just take a physician's or a psychologist's opinion. They want to see proof that either, they've had all this testing and all this treatment and nothing works, or they're in the therapy and they're working on it and the symptoms begin to improve. And only then will they really believe, okay, there was a psychological cause. Does that make sense?
Mm-hmm. Mm-hmm. Thank you. Yeah.
Okay. Yeah. Thank you for your questions and comments. Okay. Well, let's move on, and we'll certainly have some time at the end for other questions and comments. I hope you'll write them in the chat. I'm going to show you as much as I can of sort of the highlights of an initial session. Let's stop the recording. Okay, so I think that's all the questions, and we are out of time. But again, this has been a real pleasure. I hope you got something from it. I hope there's something new for you that you can think about with your patients when you go to your clinic on Monday. And please, if you ever want to talk to me, I'm always happy to consult about these matters and think together with you. And again, it's good to be with my Magyar people. I know my grandparents would be very thrilled, you know, about this. So, thank you.
Yeah, thank you very much, Maury, for this really inspiring presentation, and we really appreciate that you shared your knowledge with us about, you know, the anxiety pathways and how emotional factors can cause and contribute to physical symptoms. I have to say, my favorite piece of information was the sensory homunculus, because I didn't know that how it is connected to striated muscle anxiety. So thanks for that.
Isn't that interesting? Yeah.
Yeah. So yeah, thank you again, and thank you all for being here. We really appreciate your presence and your questions. And we would like to continue those events. So please keep an eye on our website and Facebook page. And I hope we will meet again. Thank you, guys.
Okay, goodbye.
Bye-bye.